Good morning, everyone. Happy Friday. It is a summer Friday, and hopefully some of you are going to do some vacation or some fun. Congress is certainly in recess, but that doesn't mean there's not a lot going on. So today we're going to talk a lot about what some of advocates are doing in Wisconsin, and there continue to be more and more things coming out about the impact of the reconciliation bill that was signed into law July 4th on both the Medicaid and ACA marketplace and SNAP. And some of those impacts are now starting to get clearer and clearer with the length of time that the bill has been around. People have had a little more time to think about what does it actually mean for them and their states. So the first thing I wanted to highlight, and this is actually a national article, but I'm putting it in the Wisconsin section because it kind of is about us. You may have heard over the last several months, and I may have been guilty of saying this as well, that, the impact for states that did not expand Medicaid under the Affordable Care Act is different or somehow less than states that did expand Medicaid through the Affordable Care Act. And that is kind of, sort of true and not true at the same time, which is what this article is about. So what do I mean by that? There are about 40 states and the District of Columbia that expanded Medicaid under the authority of the Affordable Care Act to cover people between 100 and 138% of the poverty line. So they added a population that had not been allowed to be in Medicaid before to provide Medicaid insurance, and that income, and they increased the amount of income people could have and still be in Medicaid. The reconciliation bill has a number of parts of it that directly impact that population of people, often called the Medicaid expansion population, in the states that expanded the Affordable Care Act. So there are lots of we call them provisions, but it's parts of the bill that are really specifically aimed at doing different things or adding more requirements specifically to that group of people. But there are 10 states, and Wisconsin is counted among them, even though we're unique, that did not expand Medicaid through the Affordable Care Act. We are counted in the non-expansion states. However, we kind of sort of partially expanded, except we used a different way of doing it. So instead of expanding under the Affordable Care Act, we used our waiver, our Badger Care waiver, to let people who kind of have all of the characteristics of the Medicaid expansion population be covered in Badger Care. But they can only make up to 100% of the federal poverty level, not 138. So we have an expansion population, but it's in our Badger Care waiver. And that really makes us unique in the non-expansion states. So there's definitely parts of the reconciliation bill that don't apply, but there's also parts of that reconciliation bill that do apply to certain people in Badger Care because they meet all the characteristics of the expansion population, even though we did it in a different way. And this article says, even if you're a non-expansion state, like Wisconsin, and I think the other states a lot of them are in the South, you are going to have big impacts because of the bill, even if there are certain parts of it that don't apply to you as much because maybe you don't have the expansion population as part of your coverage. And here's how. First of all, Wisconsin, we do have a lot of people in Badger Care who are directly impacted by parts of this bill, including the prove you're working and exempt requirements. There's a lot of things to figure out there. And there are things that apply to everybody in Medicaid, like some changes like how long do you look back and pay bills. for people who are applying to be in Medicaid. There are lots of things that are applicable to everybody in Medicaid and certain things that are applicable to certain people in Wisconsin. So we are not immune from the Medicaid cuts that happen. And of course, we've talked a lot about over the last few months that all of the different costs that states don't have now that create budget holes, not only from Medicaid cuts, but from, SNAP changes and other things create budget holes, which make it far more likely that states will cut Medicaid programs to balance their budgets. So nobody is not impacted. But the other piece that this article focuses on is, in those states that didn't expand Medicaid, that means that they have many, many, many more people who are very low income, between 100 and 138% of the poverty level, who are not in Medicaid. And if they are insured, they are paying for their insurance through ACA marketplace plans. Well, the bill also made a bunch of changes that increase the paperwork and make it harder to get and stay in ACA marketplace plans. And as we know, they did not extend the subsidies that have been keeping marketplace plans lower than they were. So for those states, including Wisconsin, that have many more people who are very low income in marketplace plans, it is much more likely that those low income people are going to be less likely to be able to afford their marketplace plans and either become uninsured or have to drop their income levels to qualify for Medicaid. And in Wisconsin, there are, I think, about almost 60,000 people that make between 100 and 138% of the poverty line who are in Wisconsin's marketplace. And if you look at 150% and less, almost 100,000 people, almost a third of the people who are in Wisconsin's marketplace plan. And we've talked in the last couple of weeks about there's more and more clarity about what those marketplace changes in the reconciliation bill are actually going to mean for individual states. So, this is not necessarily a new concept. This is actually proof in the pudding for all of the analysts who said before the bill passed that the changes that were being proposed would really result in much higher premiums for almost everybody who's in the marketplace. But now that we're getting closer and closer to the time period where those changes are going to have to go into effect, it is becoming a lot clearer and more tangible, like you can reach out and touch what the actual impact is going to be. So our friends at Wisconsin Health News just released an article a couple days ago saying, hey, insurers who are offering ACA marketplace plans have to kind of make assessments now about what they think insuring in the markets they have is going to cost for next year. And they have to file preliminary rate increases. We talked a little bit about this last week, and this has formally been released now. To no one's surprise, rates are going up in some places significantly in Wisconsin. And the analysis in the article says it seems like 20 to 30% of the people who are currently in Wisconsin's ACA marketplace might not be able to afford these rate hikes and would drop out of the marketplace, either go uninsured or perhaps make decisions to drop down into Medicaid. Maybe some of those people get jobs that have employer-sponsored insurance. That is also a possibility. But the reality is we have about 313,000 people who are currently using Wisconsin's ACA marketplace. And if 30% of them leave that marketplace, likely the younger and healthier and less costly folks, that means the folks who are left are potentially older and higher cost, and the premiums and the rate increases that we see at this moment in time may actually not be enough to cover a older and higher cost pool. So 30% of more than 300,000 people is what, roughly about 100,000 people that would disappear from the marketplace, if I've got my math right. And because we have so many middle income people who are also in the marketplace, it's not only the super low income, it's also people who are making reasonable money, but this is an increased bill that will be very hard for all of us to absorb into our household budgets. So a little bit more in the article, there are about 122,000 people who make more than 250% of the federal poverty level. And that's an important number because that's a cutoff for subsidies that lower the out-of-pocket costs. So out of that 313,000 people in the marketplace, again, only about a third of them are not directly benefiting from the subsidies that are about to expire. That means 2/3 of the people in the marketplace will be directly affected when the subsidies that are keeping premiums low don't exist anymore at the end of this year. And then there is another important cutoff, 400% of the federal poverty level. And that's the cutoff where, if you make more than 400% of the poverty level right now, you get less tax credits back. But that's a pretty small group of people in Wisconsin's overall marketplace who are above 400% of the poverty level. They are specifically drawing attention to a group of people ages between 50 and 64 that are going to be potentially the highest impacted. And they aren't all low, like there are a lot of very low income people in our marketplace, partially because that's where they are, not in Medicaid as they would be in other states, that will absolutely be impacted. But there's a group of people who may be financially doing better, who is going to be really impacted by these changes too. And it's a little bit, deceptive. They make a decent income, but they're not really ready to retire. They aren't eligible for Medicare yet, which kicks in at age 65 and covers some amount of medical bills. And they don't have access to other insurance. People between ages 50 and 64, especially depending on where they live, are in a higher risk group because of their age and typically see the risk of covering those people goes up because it's more likely that you are going to have some sort of healthcare costs. So especially for people who live in markets where they might be very rural or just the insurers expect that it will cost more to provide care in certain areas. These are another group of people who are really going to see their premiums and out-of-pocket costs potentially go up fairly significantly. And what are we talking about? Well, here's the list of the insurers in Wisconsin that provide marketplace plans, and they have filed their preliminary rate increases. Part of the reason rates are going up is because healthcare costs keep going up, and they have always kept going up. There has been no decline in healthcare costs that I can remember in my lifetime. But a lot of the other reasons why the rates are going up so much is because of all of these policies, both in the reconciliation bill and a federal rule and the ending of the subsidies. So the insurers are saying, hey, this is what we know right now, And this is what the extra money that we think we will need to keep operating as an insurance plan. Now, there may be people who say, I have a plan now, and the cost of the plan that they have now goes up to the point where they choose a lower cost plan that doesn't cover as much. But if you are in Wisconsin, 6.6% is the lowest hike that you can expect to find. And depending on where you live, almost a 35% hike is possible in some areas. And again, that matters more depending on where you live and what your age range is, because premiums typically they can be different depending on those factors as well. So these are kind of the overall base. This is how much we think we have to increase, premiums and cost share for people in order to keep running our plans. And then for individual people, those cost shifts will vary. And for some people, it may be a lot higher than just the number here, depending on the kind of coverage they need and the cost of that coverage where they live. There's also been media coverage over really the last few months, and we've kind of touched on it a little bit. You may remember in the spring when DOGE was kind of running in full force. And by the way, DOGE still exists. It's just not called that anymore. And it's still doing many of the same things that it was in the spring. There was a lot of attention and concern about what was happening to all of the different data sets that federal agencies have. And lots of court cases and other things where the argument was being made that maybe we shouldn't have outside contractors having access to all sorts of different data sets that federal agencies have about us, right? So the Internal Revenue Service, for example, is a huge group of data. Other agencies have all sorts of data, and the fear at the time that was being reported, or the desire that was being said, is, well, what if we had somebody externally had all of these data sets, and you could kind of connect and match and marry them together to find out stuff that might be individually identifiable. So there's been coverage of this over time, and a number of court cases that have allowed access to various data sets. And now there is more concern, especially because there has been an increase in immigration enforcement and policy changes that indicate that some of this data might be used to kind of target and identify and locate people who are here legally or maybe not here legally for the purposes of deportation. And we talked a little bit a couple weeks ago about a policy change that directly impacted healthcare providers that intended to make healthcare providers try and confirm somebody's legal status, their citizenship status, before providing treatment. There is a court case Wisconsin is involved in right now about that particular policy change, because as you might imagine, in many situations where somebody is providing health care, there may not be an ability to quickly confirm somebody's citizenship status. And in fact, that might be very difficult for citizens to confirm as well. What kind of questions or documentation do you actually have to be proved, eligible for receiving health care? So there was a message that our department, Wisconsin Department of Health Services, sent out, because they have had providers who have been getting many questions from people they serve about this whether or not data that's reported to the Centers for Medicaid and Medicare Services is being provided to other federal agencies and specifically to Immigration and Customs Enforcement. And they sent out a message last Friday, and I've kind of just pulled two providers to say, hey, Wisconsin is required to provide by law this information to the federal government. CMS has always kept that information confidential, and we have no idea as a state if CMS is sharing or planning to share such data with ICE. They certainly have not made states aware of that or allowed states to say no to that. Media outlets are reporting that there is some sort of agreement between CMS and DHS, the Department of Homeland Security, federal. And Wisconsin has no knowledge of it. They haven't seen that agreement. They have not been talked to by CMS. So, in terms of this is what we know that what the reports are, and we know that our Department of Health Services is not aware of that data that they are required to be provide being used elsewhere or what agreements there might be to it. They are looking into it, but it is something that's kind of been percolating along over the last several months. And now there are starting to be a lot of folks who are worried about what happens if I try to access, healthcare and I'm in Medicaid or Medicare. Is that going to mean that my data is going somewhere that I don't know about and being used in a way I don't know about? And it could have some impact that may or may not be correct for myself or members of my family. More folks are starting to use their real experience to talk about what are the impacts to real people. So this is a primary care doctor in northwestern Wisconsin who did a podcast interview. And she was talking about her patients and what she's already starting to see and kind of the erosion of trust in healthcare, where there are many people who are starting already to make decisions about whether or not to do tests or whether or not to seek out primary care because they are worried about what it will cost or they're worried about their insurance. And she also had a lot to say about, as a person in a rural area where there are lots of people who are concerned about costs or who are maybe on Medicaid or Marketplace, when you have, healthcare services that rely on those, on people's ability to pay, and those sources of funding are all of a sudden not stable or people stop using them because they're worried about cost, what that means for overall capacity to provide healthcare. So, it's another good example of if you are a person who works with a lot of people or clients or people with disabilities or older adults, it's a great strategy to talk about the people and what kinds of decisions they're making to make the impacts of this bill more real. Like they're already starting to happen even before some of the parts of the bill are required to go into effect because people are changing their behavior. And I think that this is a good example of somebody who is taking that professional experience and making the stories of many people kind of tell a story about a whole area and region of the country. So if you haven't, perhaps medical professionals or others, people love pediatricians and they really trust nurses. And some of you may work for behavioral health or other populations of people. It's really important to keep talking about the folks that you serve. So they aren't just numbers, they're actual real people who are struggling to make decisions that impact their lives. Lots of folks have been participating in events and opportunities. This is Senator Baldwin. She, for the last, we have not covered all of them because there've just been a lot of small events that she has tried to hold across the state. It's always important to step up and participate in those things if you're invited or asked, because it helps move disability issues and issues facing family caregivers or care workers to the front. That we always want to be part of the conversation. And there has been coverage of these events, mostly through local papers. But again, any kind of coverage is helpful in the sense that that becomes something that you can share with your networks. And a lot of times if people know you, they go, ooh, I know the person in this TV story. And that's something they can talk about with their friends too. A number of folks have also been sending in letters to the editor. So here's an example about from a parent with a young son on the autism spectrum and what Medicaid has meant to them as a young individual and why it is so important to their son's success in the future. I won't read the language, but I thought she got pretty direct in that. Another example, and this is a particularly good one because if you look at that second and third bullet here, you can really do some compare and contrast, right? The second bullet really in 3 or 4 sentences identifies what it means when you don't have good access to health care. What does that look like and what does it actually mean for families? And this third bullet is very good about saying, hey, that's not my reality now, and what a difference it makes. And I do think that that's a really good strategy and also really important because there are lots of people who are making decisions in various places, state agencies, federal agencies, lawmakers, who maybe don't have the experience of what it's like to not have access to healthcare. They need people with that experience to make it very real for them because they may have always been in a position where they've had, say, employer-sponsored health insurance. It's not their fault. It's just that's been their reality. And it's important for us to keep saying there's a lot of different realities here, and those changes are more impactful than perhaps they first realize. We last week put together a couple of different letter to the editor scripts on request, and it seemed like that was popular. So we're going to try every week to do another script. There's so many things to talk about that I feel like all of us on this call could probably write a letter to the editor about a different thing every week, and we would not run out of material. This time, we did a sample ACA marketplace script because there's certainly a lot of care workers and family caregivers and people with disabilities and older adults who get their insurance through an ACA marketplace plan. And so now it's starting to become more real and more newsworthy, what those changes actually mean to individual people's lives. We still have survival survey out. Not still. We're running it through the middle of September, and we've asked people to share it widely. We're making some progress on our goal to 1,000. Last time I checked, which was a couple of days ago, we're 25% of the way to our goal. So keep spreading the word, keep helping, keep making sure, checking in on your friends, checking in on your listservs. Remind folks to take the survey. We'd like to get a really good sample to be able to, again, reflect out what people's experiences are across the state. All right, now we're going to move to Congress. What are they doing? So we're here August 15th. 45 days before the end of the federal fiscal year. That's important for a couple of reasons. We have talked about rescissions, additional rescissions bills coming. And this has been the magic date, August 15th, because the Office of Management and Budget Director, who has publicly said, yes, I want to do more rescissions packages. I want Congress to agree to take back money that it said it wanted to spend and say it doesn't want to spend it anymore. This has been his magic date because 45 days before the end of the fiscal year, if there's a rescissions request, he interprets the law as allowing him to pause spending. In other words, you don't have to spend money you're asking to take back. And then, of course, at the end of the fiscal year, most of the federal money expires, which means you can't spend it anymore. We have not seen any coverage of additional rescissions requests, and we're going to get into another strategy that may be being used. Okay, so we are now in a place where September 30th is the end of the federal fiscal year, and we are mid-August. Congress is not coming back until September, and there's a very short window to see if they can get the budget for the next year either done or a continuing resolution that allows some spending or all spending to continue while they figure it out, or the government shuts down and certain parts and certain funding just stops flowing to states. So we're honing in on that part of the timeline. We're starting to get really focused on it. There's continued discussion of a second reconciliation bill, which we'll talk about in a few slides, and some bigger picture political landscape stuff that may impact a lot of this. Some Democratic senators are still working in good faith and trying to find bipartisan agreement on things that they want to spend money on in the 2026 budget. But there is a growing, grumbling group of senators who has pointed out that the passage of the July 18th rescissions bill really means that Congress went back on promises to fund certain things. And that is making it really hard for more and more members to say, how are we negotiating and coming to agreement on spending when those agreements may not mean anything if you come back and do more rescissions requests. And I think that there are some members who are warming up to the idea of maybe either doing allowing a government shutdown to happen, or really trying to put in some very strong language that prevents the administration from freezing or taking back or using money that Congress has said should be spent one way in another. And we'll see how that's played out. But over the last few weeks, we've kind of seen growing concern about, we're working on these budget agreements, but is what we agree to going to be what happens if we have, given the behavior that we've seen thus far? So one of the things that came out last week, we did talk about the U.S. Senate committee, had its plan for the Department of Labor, Health and Human Services, and Education come out. And they had a report that came out with part of that. We know that the House probably has a very different idea of how to spend money in those departments. We also know that that's kind of the biggest overall bill in the 12 bill appropriation package. Well, buried within that report is a reference to, again, a theme of, we several months ago covered a proposal that the Federal Department of Health and Human Services had about using all sorts of external information to kind of come up with a way to look at and study and track autism. And it was a big story a few months ago, probably in April and May. And then it kind of disappeared a little bit. And we saw the department walk it back and say, oh no, we're not doing a registry. Lots of advocates were like looking at that. And it looks like the US Senate report is pointing out that on page 150 of its 400-page report, by the way, that it looks like this idea has not died, and that part of DHHS's plan is to simply revise an existing project and do a similar strategy and apply it to autism. So while the committee report raises concerns, it doesn't have the force of law to stop that. And it certainly is noting it because that particular project, originally targeted to Alzheimer's research, Congress had a lot of concerns about, and for good reason. In fact, the National Institutes for Health abandoned the project because of Congress's concerns. So I think there are a number of folks who are saying, hey, wait a minute. We had all these concerns when it was targeted to this group, and now you're doing a similar thing that we told you not to do for another group. It's been noticed. So there's some concerning reason to believe that the autism studies and the desire to use many outside data sources to kind of collect information and use that information in unknown ways may be continuing. And some indication that there's been an agreement, again, that is unknown between the National Institutes of Health and the Centers for Medicaid Services to share data about enrollees with autism. Obviously, that's as much as we know, but it's being publicly covered now by independent reporters, and it is included in the Senate report. So, it does seem like the original questions that advocates raised, and I know national autism groups were on this earlier this spring, still remain relevant. They're valid. And it's a question that individual people can ask their members of Congress. What data is being collected from where, and what is the government planning to do with it? And are they going to be making erroneous conclusions that have an agenda that isn't really about providing better help for people with autism? The other thing we talked about last week, we were encouraged by the Senate committee, not defunding disability and aging programs and keeping the existing structure that is in the 2025 budget. And I think that this week we got an important reminder from national disability advocates that while that's a really good first sign, it isn't the end product. That there's lots of reasons that, reasons as in lots of advocates from across the country have made a very public and good case, and that is partly what we see reflected in the committee, that they have continued to fund things like our organization and disability rights and other things, and they're not necessarily interested in doing the things that were in the president's proposal. But that doesn't mean that what the Senate committee passes the full Senate, first of all, or that the House that has to do a version of this same appropriation bill agrees. And there's a lot of room for changes that are very different from what this committee has done. And a little bit of a warning that the House and the Senate are not in agreement on these issues. So there may be more of a desire for the House to make cuts that are to programs that are important to people with disabilities and older adults. a little bit more about the timeline in this article, again, I pointed out, September is coming and we're 45 days from the end of the fiscal year. Congress isn't going to be back for another 2 weeks. That's really not a lot of working days to get a federal budget done. And sometimes Congress creates crises for the purpose of making changes and doing them quickly. And we've kind of seen this over the last year in a number of ways. That is a strategy that lawmakers often use, is they kind of create a situation where things have to happen, and that becomes a lot of pressure to negotiate or give on certain things or make cuts or make a big bill that is really complex that people have to vote on and they can claim they don't know what's in it. We don't have time to slow it down. We kind of saw that strategy play out not only in March when we were worried about the 2025 budget and we had, a continuing resolution or shutdown looming as of March 14th, but we also saw that as a strategy in the reconciliation bill. When you saw the US Senate, for example, have 0 hearings or markup sessions on the bill and then pass it over the weekend in under 4 days, for example. So I'm just pointing that out to kind of show you that the window for action is narrowing and that there is a strategy here that packing a lot of activity into a very short amount of time enables you to hide things or do things that maybe folks, if they had a little more knowledge of what was in it or a little more time to react, might raise questions about. So I think it's still relevant to really keep pushing lawmakers to say, hey, not only do you have to make sure these programs are funded, but you have to make sure that the funding actually gets to where it needs to go. And how are you going to do that? So I already talked a little bit about rescissions. There is another strategy that is similar. It may have kind of the same outcome that people are starting to talk about. And you might remember last week, because I asked this of our national policy person, I went, do they really have to even ask for rescissions bills? Because we're 10 months into the federal fiscal year, and there are lots of places that simply have just never received the money that Congress appropriated for them. And Congress hasn't really asked about that. It seems like you can just if you can just hold on to the money and not release it until the end of the fiscal year, then you don't have to spend it. Well, that does seem to be a strategy here. So rescissions request, again, is when the administration asks Congress, hey, take back this money you agreed to spend. We don't think you should spend it. And if Congress agrees to that, then money that they agreed to spend, legally cannot be spent. A deferral request is slightly different. And that's when the administration asks Congress to temporarily say, hey, we're not going to spend this money that you wanted us to spend for a period of time. There may be reasons, that you might make a deferral request, right? Like, hey, we have an infrastructure project and we're behind schedule and we don't have a project that we can spend the money on now, but we will in a month. Like that's an example of where you're not saying you won't spend the money, but you're saying I can't spend it now because the things that you wanted me to spend it on are not ready yet. There is under the law a very small group of reasons that the administration can pause spending, defer, without asking Congress. Now, it's important to know that they can't pause it just because they don't like the program or policy. And the law specifically says you can't use a deferral or temporarily pause money that in a way that makes sure the funds can't go unused. However, this administration has pretty liberally interpreted laws thus far and has done many things that no one has ever done before, including withholding money that Congress absolutely said should be spent. And Congress hasn't done anything about that. Both rescissions and deferral, whether or not the administration asks Congress whether they can defer or tries to make the case that they can pause the money without asking Congress. They both have a similar end goal. It means that money that Congress approved doesn't get spent. And that's important because generally there's a deadline that Congress sets and says if you haven't spent the money by this date, then you can't spend it. Your ability, your authorization to use that money goes away. Oftentimes, the money in the federal budget has an end date. It may be longer than a year, but sometimes it's not. Usually, you may have a project that you have to spend the money within 3 years or 5 years. But the reason Congress uses end dates is because they don't want to have money that somebody agreed to spend in 1977 still unspent in 2025, right? So you're setting a window of we have an expectation that the money for this thing that we are agreeing to is spent in a time period that is going to impact, the world we know today and possibly into the near future. Already, there have been lots and lots of pieces of federal money that have been withheld in more than a dozen federal agencies. And, Congress hasn't, in some rare instances, and disability services is one of, thanks to outside pressure from people like you, there have been a lot of places where Congress really hasn't called the question with the administration, and it hasn't challenged or said no. It said no. Hey, we appropriated this money. Your job is to get it out the door. It's been silent on that, and so there's funding that if it doesn't go out the door by September 30th, it expires. The authority to spend it expires. And so what does that mean? It means that the administration effectively has just held certain pots of money and it's never gotten to where it's supposed to go, and then it can't be spent. So it's maybe time to ask some questions about that. You already have promises you made in the 2025 budget that were never fulfilled. So what are you going to do about that? And what are you going to do to make sure that what you promised to fund in 2026 actually gets funded? There's been a lot more discussion, again, of a second reconciliation bill. As a reminder, you can do one reconciliation bill per fiscal year. The new fiscal year, federal fiscal year, starts October 1st. So that would mean as early as October 1st, Congress could move a reconciliation bill. Reconciliation is kind of a special bill in this. It can't include, it's kind of like it's limited in terms of it has to be budgetarily related, and there's a couple of things that it can't cut. And there's certain rules about how language has to be worded. But the big reason why reconciliation bills are such an appealing mechanism to move forward pieces of legislation or spending cuts or spending increases is because instead of requiring 2/3 of the Senate to agree, it only requires a simple majority, 50 plus the vice president in this case would be 51. And that's why we saw this big reconciliation bill move using reconciliation as a process, because it needed far fewer votes in the Senate to be able to make it over the line and become law. So And both parties have used reconciliation as a process for more and more legislation, really since the Bush administration. So it is a process that keeps getting used because it means you have to have fewer votes in the Senate. So there's already talks, at least on the House side, of what would we put in a second reconciliation bill. There were definitely, and over the last few weeks, you've heard us cover that there are definitely people who would like to see some of the Medicaid cut ideas that maybe didn't make it into the final reconciliation bill that was signed July 4th come back. People who had things that got dropped from those bills because they didn't meet the specific Senate rules called the Byrd Rule requirements. There's also been folks who want to make up to 200 different kinds of other tax cuts and people who want to make a lot more spending cuts. So this is not a new conversation, but it's getting to be more specific. And the House committee has kind of a Republican group who is actively talking about what to put in the bill. The Senate is not as wild about a second reconciliation bill, although the Senate Appropriations Chair, who has a lot to do with whether or not it happens, seems open to the idea. And there's certainly some fiscal conservatives, including Wisconsin Senator Johnson, who are supportive of it. Other senators are kind of lukewarm on whether to do it. We've seen that happen over the last year quite a bit, where people are kind of publicly saying, I don't know about this. And, that isn't necessarily a sign it doesn't happen. But the thing that happened this week is that the Paragon Health Institute met behind the scenes with Republican members of the House and talked about some of their ideas on what they thought should be in a second reconciliation bill. And they're important because they have had some very strong views, very much aligned with Project 2025. In fact, some of the same people have contributed to both documents. And they came out with a report last year that really advocated for big changes in Medicaid, specifically block grants and per capita caps, which are a way of really reducing the amount of money that goes to states and deepening those cuts over time. We may have to talk again about the specifics of what those two ideas mean, but it was a big deal in February when those two ideas were kind of taken off the menu of Medicaid cuts by the House Speaker because they were too big. They were not agreed to at the time. But they met yesterday with members of Congress, and they did a few things. First of all, there's been a lot of Democrats who have, mostly Democrats, but also people who are just concerned about healthcare, who have said, yes, the reconciliation bill does in fact cut Medicaid, and those things are going to hurt, not only individual people, but they're going to hurt people that you are claiming you don't want to hurt, and they're going to hurt the entire healthcare system. Things that we've been talking about, like fundamental, like this is what the analysis tells us is going to happen if you make these changes. And we've also talked about how part of the strategy for folks who voted in support of those changes has been to either say those aren't things that are happening, or to try and sell the bill as preserving Medicaid or helping vulnerable people or other types of things. Lots of reasons that those things aren't true. But part of what Paragon apparently was talking about is, here's the way that you Republican messengers can counter what the Democrats are saying about the Medicaid cuts. They also started talking about reforms to Medicare Advantage, eliminating fraud. We've heard this before as a code for, here are changes that that are cuts that we are going to frame as a way to address fraud for people who are in the Affordable Care, who are in Medicaid because of the Affordable Care Act. They also put out a big number. And they said that Congress really should be aiming to cut another at least 1 trillion in the budget reconciliation bill, and that you might need to make cuts even if they won't be politically popular. They also shared their own report, which is very different from the government's report about how much improper payments are, in Medicaid specifically. And we've seen this before, where there's not only been an overestimation of how many improper payments are, but an incorrect association that improper payments means fraud, when that is not what it means at all. Most improper payments are really mistakes and paperwork mistakes that have nothing to do with whether or not the service should or shouldn't have been provided. In fact, about 5%, I think, of the improper payments are actually in that category where they might be fraud, right? So it really feels like we are kind of gathering some important data about what might be coming. Another thing, just for folks on this call to note, is in Wisconsin, there was a healthcare panel a couple weeks ago where one of our sitting Wisconsin senators mentioned that she had been at a conference, I believe an insurance conference, and had talked to Secretary Kennedy. And she shared with the panel that she did not believe Medicaid block grants were off the table. So, we don't, in the world of things we absolutely know, we don't know what is coming, but certainly we can see that there are lots of people who have supported and been very specific about structurally changing how Medicaid works in a way that would be very hard to change back and would really create huge budget holes for states and potentially drive spending for in Medicaid only for the highest cost mandatory services. Those ideas are still being talked about, and they're being talked about in the sense of, we think you folks need to cut another really high number. We already cut 1.2 trillion from healthcare, almost 990 billion from Medicaid alone in the first reconciliation bill. This is saying we need to cut about the same amount in a second one. So there's a larger political landscape here that may impact whether or not some of these ideas move forward or don't. The first one is, now there's starting to be some reality about what are the consequences of the ACA marketplace subsidies expiring. And Congress knows that costs for ordinary people are going to go up if they don't extend those subsidies by the end of the year. I want to remind everybody, Congress chose not to do this. They could have put that extension with all of the other tax stuff they did in the July 4th reconciliation bill. They chose not to do that. That might have been a deliberate strategy, because as people see that their costs are going up and want to see Congress do something about it, that means that that subsidy that's expiring at the end of the year is leverage. It could become a bargaining chip. So the fact that Congress didn't act has now created a crisis. See a pattern? A crisis that has to be addressed within a certain time period. And we have seen some members of Congress be interested in extending those subsidies. It costs something to do that. It's about $30 billion a year, but a little over $300 billion over 10 years to keep the subsidies as they are right now. And you can kind of see a playbook where, well, maybe we'll extend the subsidies in exchange for cutting Medicaid and Medicare more, right? So you're kind of pitting populations of people against each other to do one thing that needs that lots of people support. You are also going to ask for permission to do all sorts of other things that might hurt other people, right? And this is, again, much like the budget that's coming up, where you've had deliberate non-action and you're waiting until the end of a deadline to do a whole bunch of things. This is another crisis point that in some ways has been created by Congress that could be used in a similar way. The other big thing going on, and we haven't talked about this as much, is a conversation about redistricting in other states. Every 10 years, the state legislators draw maps to create legislative districts. Districts are just lines on a map, and the legislators represent everybody who lives in that area. If you live within the bounds of that map, you're a constituent and you're represented by that lawmaker. Now, over the years, and this has happened in the state as well, you get to know that there are certain places or certain kinds of people or, all of the data that you have about who votes, how often, where, and some ideas based on the results of elections of how those people are voting. You can kind of identify where there are many people that tend to vote for the same political party. And sometimes lawmakers want to draw maps so that they can pick voters who they know will probably vote for one party or the other. And that makes those districts, those places, reliable Republican or Democratic districts. It means that you can kind of design who your voters are and steer or kind of project what the results of an election could be based on who lives there before an election even happens. There's a word for it. It's called gerrymandering. Now, there's a requirement that states have to redraw the maps every 10 years, but I don't think is a provision that they can't do it sooner than that. And so one of the things that is happening, there's a small majority of a Republican majority in the US Senate and the House. And President Trump has approached Texas and some other states that have reliably elected many more Republicans to Congress than not, to redraw their maps early. So not take the entire 10-year term, but redraw the maps, 5 years in. And he's been very transparent about the reason he wants the maps redrawn now is to make sure that there will be more Republicans elected to the US House, maybe 6 seats more. That matters because if you have more folks elected from the same party, then you have a bigger majority, which makes it harder for the other party to negotiate or get some wins. And it also means that you can lose a few more Republican votes without actually losing a vote on a bill. It makes it easier to pass laws and budgets. Now, this is important because there's conventional wisdom would say, well, hey, we just passed a big bill that has a lot of impacts that people don't like. So lawmakers aren't going to want to make more big cuts or changes that voters who might be thinking about, the 2026 election in the fall already don't like. We don't want to do more things that would cause people who vote to question whether or not current elected officials keep their jobs. That's conventional wisdom. And certainly the reconciliation bill that's just passed has made big cuts and changes that aren't popular. And some of those changes, specifically ACA marketplace changes, are going to be in effect before the 2026 elections. So if states draw new maps, then where predictably you can predict that you will keep your current majority, even if it's not all the same names who are, in the seats, right? Like maybe there are people who lose elections, but, your majority and your ability to say that Republicans can control the agenda control the committee assignments, control what gets to the floor, all of those things that are associated with being in the majority can keep that power, then maybe it doesn't matter as much if you do big things. So, this isn't necessarily a disability issue, but it really does change the possibilities for what can be done. And if you are in the position where you've redistricted and you know that you're going to have the same majority or more than you have now, then maybe you redistrict and you can do things like a second reconciliation bill that has pretty big changes and not worry about as much about whether those changes will be rejected or by voters, and you will lose, your seats in Congress. The other thing is we still are learning the impact of the reconciliation bill. And I think we will get, again, one more wave from our friends at the Congressional Budget Office. This week, they released an analysis that was really a two analysis. One was focused on they call it distributional effects, but really it's an assessment of, okay, who benefits the most from this bill and who benefits the least. And this won't be a surprise to folks on this call that the people who are in this upper 10% of household earnings are going to do the best, mainly because the extension of tax cuts. And top 10% depends on where you live, but it's generally households that are earning at least or more than $191,000 a year. It's the bottom 10% of the earners, people earning probably under 25,000, who are likely to be the ones that actually see a decrease in their income. There's been a lot of coverage, but here's the actual assessment that the Congressional Budget Office says, hey, we've looked at the bill, who benefits, who doesn't. And yeah, it is the people who have the most who benefit for the most, and the people who have the least actually do worse under the bill. There was a second analysis this week also that just looked at the parts of the bill related to SNAP, which is food assistance. And they didn't look how all these parts interact with each other, but they did come up with, yeah, doing all of these things that's in this bill is going to result in about 2.4 million people being dropped from the food aid program every month. So we don't have much to talk about the administration this week. We're getting close to the end here. This is a plainer language version of what we talked about last week, that there's being, again, a repeal of a rule that helped people in Social Security not have a third of their income taken away because they live with somebody else who is expected to provide in-kind care. So this is just a plainer language. It's not a different policy from last week, but I included it because I thought it was a little clearer worded. And we have a ton of coverage. Again, these are all articles that you can share with your networks. You got your own social media schedule or listservs to put out. Lots and lots more coverage about not only the marketplace, but what it means, what the reconciliation bill means for Medicaid. So this particular piece focused on young adults who are now entering, who are not in employer-sponsored plans. They don't have jobs that provide health insurance, and what it is like for them to be able to pick plans that they may or may not be able to afford. It's a lot of young people who are in that situation. A lot of them are actually saying many of the same things that we hear from older adults about trying to pick a plan and taking a risk that they won't have to use it. Importantly, there are about 15% of this young, healthy group who you really want to be in the pool so that they keep everybody's costs down, who are going uninsured for a variety of reasons, both costs, but also, it's just so hard to figure out what to do. And that almost half of people in the youngest age group have incurred medical debt. Which I think is a pretty amazing, not amazing statistic. It just shows you that it doesn't, even if you're insured, you may end up with a bill that you can't pay. In the same vein, another article is really calling on that question. And this is aimed at people who are maybe close to retirement, but not yet Medicare aged, or people who are thinking about starting a small business or a contractor where they don't have health insurance that are associated with it. This article actually has a calculator in it and says, hey, with all of these changes that are happening right now, you have to really assess how much do you have to earn to be able to afford a plan. Big main media market article that kind of puts it all in one place. How is this new reconciliation bill essentially a repeal of Obamacare, which some of you are old enough to remember was attempted in 2017? They kind of call this a repeal light, where we didn't repeal Obamacare, but we did enough policy changes where the effect is about the same. More and more coverage of how a different set of policy changes, immigration policy changes, is actually impacting healthcare, and specifically long-term care, including home and community-based care, pretty significantly. We've talked about this before, of how many immigrants make up the caregiver workforce. That's also true of medical professionals, right? So, and in the home and community-based side, many of the workers that are in healthcare who are immigrants, these are the exact workforces that we don't have enough of. So the combination of existing low pay and low benefits crisis that many of us have been talking about really for decades is being kind of amped up on steroids with additional policies that make it less and less likely that the workers who are in those jobs are going to stay in them. And you can see this having an impact on the overall healthcare, system, not only with people who need folks in their homes to provide care, but also just basic logistics of hospitals can't discharge people who don't need to be in the hospital if there's no place for them to go. And oftentimes, there's no place that a rehab center or a nursing home that they can discharge a patient, because those places don't have workers. And a good portion of their workforce are actually immigrants. So all of the things that are really problematic now from a healthcare system perspective really feel like they're not only going to get worse, but kind of accelerate and get worse. An article, states have no idea how to do the things in the reconciliation bill, but they're pretty sure that many of them will be in the place where they reduce services, something we've talked about since February. So now you have an article that says the same thing. And there are, again, a number of pieces. There's been a lot of coverage of rural healthcare in the last few weeks. And specifically a couple of different kinds of healthcare clinics, federally qualified health centers being one, and also rural nonprofit hospitals who are disproportionately impacted because they serve many more people who are in Medicaid or Marketplace, first of all, and they also have some rules of not being able to turn people away or having to provide charity care or other things. That means that as there are fewer people who can afford to pay, they still have the same costs and no money to kind of cover those costs. The article also has a lot of information about impact to individual people. We have a lot of folks in this country already who have some sort of medical debt. In other words, they are insured, but their insurance did not cover enough and they couldn't afford to pay the balance. And obviously, if you're uninsured or there are certain populations of people, including people with disabilities, your risk of having medical debt increases. But it's important to know that these healthcare costs are so high that it's a major factor in whether an individual goes bankrupt. So just, as you're thinking about what are the downstream effects of having more people who have plans that cover less or higher cost share requirements, or who are going uninsured, a lot of those extra costs that consumer can't pay end up being might be a bankruptcy inducing event for those folks. Our friends from Michigan tried to implement a work requirement program a number of years ago, and they were told they couldn't by a court, but they got pretty far along the process. And this article is a good cautionary tale of, a state that was trying to do the least amount of harm by work requirements still almost had 80,000 people who were going to lose coverage within 3 months because the system couldn't figure out whether or not those people were working enough, or they couldn't provide enough documentation that they were working. We've talked a lot about the challenges states are going to have and the risk that individuals who are in Medicaid either won't be able to complete the paperwork or do enough to prove that they're meeting to prove your working requirements or prove they're exempt. This is just another example of, here's a state that tried really hard to do its best to not have people lose coverage. And there were a lot of people who were going to lose coverage. Another piece, this one focused on SNAP, and we haven't covered this as much. This piece is focused on veterans. Another way that you apply provisions to more and more people is that you remove existing exemptions. And SNAP has always had work requirements in it. They've expanded who is covered under that. There have been exemptions for certain groups of people. Veterans is one exemption. Homeless people and kids aging out of foster care are other people who have been exempt from these work requirements in the past. And you can see that those populations of people have generally some additional barriers to employment that make it more difficult for them to be able to find employment. Well, one of the things the reconciliation bill did is it removed those exemptions. And by doing so, not only have you expanded the age of who has to do work requirements, you've also removed some of the people, you've added back in people that you did not have to, that were not required to be part of those work requirements. And for many of those folks who have a harder time and were exempt in the past, not only do they have to know that they have new requirements and see if they can do them and all of the things that are challenging, but it also means that you're increasing the likelihood that there are many more people who get food assistance now who may not in the future, simply because we've made a policy change and they are now subject to requirements that they cannot meet. All right, I'm going to stop talking. I've talked long enough. And if there are any questions.
There was just one question about the Paragon.